Okay, so let's we start. Assalamu alaikum. Today we have to discuss chronic viral hepatitis and CLD, chronic liver disease. We discussed last acute viral hepatitis due to hepatitis A, acute hepatitis due to hepatitis A, hepatitis E. So today we discuss acute viral hepatitis, hepatitis B, C, and the chronic hepatitis and chronic liver disease, and what is the management of chronic liver disease. So what is acute hepatitis? B, C is the clinical feature and management are similar as acute hepatitis A caused hepatitis. So signs, symptoms and management of acute hepatitis B and C is same as a hepatitis A. The course may be indicted, subclinic episodes are extremely frequent. The non-icteric case is more liable to become chronic than the icteric. So the child may not develop the jaundice or not appear jaundice, but later on maybe develop the chronic hepatitis. So it's not mandatory that the child who develop the hepatitis, jaundice or hepatitis and in history, but yes, you have to ask the history there. Yes, in past history there is jaundice or not, but sometimes non-icteric case may be develop the chronic hepatitis. The relapses are rare, like was let's say in the cholestatic hepatitis, the prolonged weak jaundice is unusual in the hepatitis B and C. Acute hepatitis B is self-limited in 95 to 95%, but hepatitis C is only 15%. So if it is hepatitis C, it will lead to the chronic hepatitis in the 85% of the cases. The routes of transmission for hepatitis B is vertically between the mother with the mother infected and with the chronic infection can be transmitted to the baby. It is called the vertical transmission. So it's more common in the hepatitis B. Horizontal transmission through close person-to-person contact can be transmitted, but it is as it is in the adults, it's rare in the children. It can be parentally by the injections, blood transfusion, and so hepatitis B infection. We have to know about hepatitis B infection, how you to diagnose, and what are the parameters to use and define and characterize by hepatitis B virus. So hepatitis B virus antigen and host antibodies for you have to know about for the diagnosis. Hepatitis B virus DNA and genotype, load of the viral load and genotype. We know for the prognosis, biochemical markers for the status for the acute or chronic hepatitis, degree of hepatic fibrosis, inflammation for the chronic hepatitis, and chronic liver disease. So chronic asymptomatic subject is hepatitis B way. We have to follow for if they are asymptomatic and chronic acute hepatitis B infection, which may be subclinical, because 1 to 10% of patients will not clear the virus and most will become carriers of hepatitis B surface antigen. The asymptomatic carriers usually discover incidentally on blood tests, such as when they are screened for donating blood for transfusion. They have no evidence of active liver disease. Most remain surface antigen positive but do not develop the active liver disease. There is an annual response clearance rate of 1 to 2% for hepatitis B surface antigen. So we have to follow them. If they are chronic carriers, there is no symptoms, liver is normal, and 1 to 3% can clear annually. These patients need to be followed. What about the chronic hepatitis B infection goes through a replicative integrate phase. In the former, there is active viral replication with inflammation mutation is highly infectious with hepatitis E antigen, hepatitis B virus DNA positive. At some stage, the viral genome becomes integrated into the host DNA and the viral genes are then transcribed along with the those of those. That's why hepatitis B is very difficult to treat and eradicate the virus because it is integrated to the host DNA. You have to clear, but it is just lab will be normal, but it can be there because it is integrated into the host DNA and go into viral gene, go into the human genes. For the clinical features of chronic hepatitis, more frequent is often not prescribed acute hepatitis. So 50% present with established chronic liver. Investigation you have to go for baseline investigation LFT, bilirubin, PTFD, but other viral markers you have to go discuss detail. There is some extrahepatic manifestation, polyarthritis, glomerulonephritis, Guillain-Barré syndrome. What is the course of nature history of the chronic hepatitis? The child who have a hepatitis, liver jaundice, or there is HCPT more than 6 months available as chronic hepatitis. So some will be asymptomatic carriers, some will be chronic hepatitis B infection, and some will be chronic hepatitis. So if there is chronic hepatitis, what will be outcome? They can go into the cirrhosis and can go into the liver failure, hepatocellular carcinoma, and ultimately, if there is no liver transplantation, death can happen. What is the sequelae of the hepatitis B virus? Like hepatitis B is well known for bed for the babies. How acute hepatitis will happen? There is a 1 to 5% will be developed the acute fulminant hepatitis, and other remaining will be persistent infection. It will be carrier. It can be chronic hepatitis. Chronic hepatitis turn to the cirrhosis in hepatocellular carcinoma, and some of the cases will recover and develop the immunity. There is a percentage of recover from acute hepatitis. Like recovery rate in the neonate is 5%. So if the newborn infected from vertical transmission from the mother to the baby, there is 95% chances for the patient will be not recovered, newborn will be not recovered, and it will lead to the chronic hepatitis. So there is a recovery rate in the newborn is only 5%. What about 1 to 5 years? It will be 75% recovery rate, very good, above 5 years. So hepatitis B, if it is there, the whole 5 years, there is 95% recovery rate, only 5% will go into the chronic hepatitis. While about the hepatitis C, less than 1% will go into the fulminant hepatic failure. 60 to 80% will develop the persistent infection, and there will be normal HCPT or go into the chronic hepatitis, cirrhosis, and hepatocellular carcinoma. 20 to 40% chances for the eradication for the. So it's a very familiar. If you remember, for hepatitis B in pediatric hepatitis B, wait for babies, and hepatitis C, like it will go 85% children will go into the chronic hepatitis and chronic liver disease. This is the course of acute hepatitis. The diagram restitution. When there will be symptoms there, there will be surface antigen positive, hepatitis B virus DNA positive, E antigen will be there, and later on will be recovery phase. That E antigen, E antibody will be appear, IgM core antibody and total core antibody will be appear. So this is the very important slide to remember that how you to interpret when you go for surface antigen, anti-core antibody, anti-surface antibody, IgM core, and total and Ig core antibody. So when there is nothing is, so if the child is susceptible for infection. When anti-surface antibody is positive, like after vaccination, immune due to the vaccination. And if there is a anti-core antibody and surface antibody is positive, the immune due to the natural infection. And if it is surface antigen positive, anti-core IgM, total antibody body, the anti-core IgM positive, then it's acute infection. If it is surface antigen positive and anti-core antibody positive, it's a chronic infection. So if it is only anti-core antibodies, the interpretation unclear will be not here. So again, other on the basis of the hepatitis B markers, anti-surface antibody positive immunity, the child will be immune. Anti-core antibody positive only, then will be exposure, and surface antigen hepatitis B virus is show the infection. E antigen or hepatitis B virus DNA is show the replication. Along E antigen with hepatitis B virus, DNA positive replication is here. Infection is going on. IgM anticore antibody and or hepatitis B virus is there, so it shows the disease. So what is the treatment of hepatitis B? It's self-limiting, it is acute, and does not require any specific treatment. Patient should be followed to detect chronicity. So you have to follow child for 6 months. If it is clear, no need self-limiting. If it is remain more than 6 months, it's a chronic hepatitis, then you have to decide it's need the treatment or not. So who to treat children with chronic hepatitis B virus surface antigen positive more than 6 months, and better response regarding the treatment is if they have a high LP, inflammation on the biopsy, low hepatitis B virus DNA load, late acquisition infection is there, then there is a good response for the treatment. And goal of the treatment in pediatric population is to reduce the risk of hepatitis B virus related cirrhosis and hepatocellular carcinoma. Elimination of E antigen may consider improve the prognosis. So you have to prevent only for the patient, our child now going to chronic hepatitis, cirrhosis, or carcinoma, and you have to remove the E antigen. So treatment, there is options like interferon and lamivudine. It's three main drugs which is used for the pediatric chronic hepatitis. Others, entecavir and endofir is used, but in the these are recommended interferon and lamivudine combined. So it's interferon 58% response. It is given by subcutaneously. What about the lamivudine? Is a oral drug, anti-viral drug. So it's, when used, its response is 23% oral cheap drug, but they have some risk for resistant that's used multiple times. Good for the hepatitis B is that vaccine. Vaccine is available. You have to routine. It is included in the API vaccine. And if they post exposure, you can use hepatitis B immunoglobulin. What about for infant born to the hepatitis surface antigen mother? Is very important. As we know that if the mother is hepatitis B positive and baby, there will be 95% chances that they will not recover. So there is only 5% chances for recovery. So there is when there is a mother is hepatitis B positive, we have to screen for the mother and identify the newborns. If we give the vaccine and hepatitis B immunoglobulin within 72 hours, efficacy we have to recover our chances for 95% chances for the recovery for the baby. Alternately, if not, hepatitis B vaccine immunoglobulin not given, then will be 95% chances for chronic hepatitis. But if you give the hepatitis B immunoglobulin and vaccine, there is a chances for 95% recovery. And efficacy for these to indicate the virus. Whatever hepatitis C, the children, it will be normal growth, mostly are asymptomatic in chronic hepatitis. Hepatomegaly, incidentally, we go for abdominal examination 2 to 61%, hepatomegaly, and 44 to 93% enzymes, acute enzymes, SUBT, SGOT increase. How you diagnose hepatitis C? You have a hepatitis C antibodies and PCR. So hepatitis C antibodies is initial screening and diagnosis. Then you go for the confirmation, like you go for hepatitis C virus, RNA, PCR. There is a two type, one is the quantitative and in the qualitative. For confirmation only, qualitative is required, but quantitative for PCR, hepatitis C virus, quantitative for pre-treatment, that's what is the viral load, and post-treatment monitoring for the PCR hepatitis C virus. Risk factors for vertical transmission is we know hepatitis B is transmitted. Majority of the cases, hepatitis C can be transmitted if it is increased chances when they'll be used for internal fetal monitoring devices used. There is chance of hepatitis C transmission, high viral load, and prolonged rupture of membrane more than 6 hours. There is a chances for the hepatitis C virus, and if they have a co-infection with HIV, then hepatitis C virus can be transferred from mother to the baby by vertical transmission. Otherwise, very less chances for vertical transmission from mother to the baby. So what is the nature history of hepatitis C virus infection? 15% will be resolved, 85% will develop the chronic infection, 20% cirrhosis, and 6% per year in this stage liver disease, and 4% per year with cirrhosis. The course prolonged in the hepatitis C, it takes 10 to 20 years to develop the chronic hepatitis and cirrhosis in hepatitis C. So outcome of hepatitis C virus in chronic hepatitis, if there is actually 85% chances that hepatitis C will go into the chronic state. Then viral markers, yes, SUBDLT will be raised when there is a symptoms. So there will be 20% will be symptomatic, 50% will be asymptomatic. So if symptomatic, when there is jaundice, LT will be, AC will be raised, and you go for the PCR hepatitis C virus, RNA will be positive, and antibody will be here. So you can diagnose both by the hepatitis C antibodies and the PCR. So interpretation, what will be the hepatitis C virus antibody, hepatitis C virus RNA by PCR? If both is positive, what will interpretation that acute or chronic hepatitis C virus depending upon clinical? If it is acute, like there is a hepatitis, hepatomegaly, there is no sign symptoms after clinical statement of chronic means that there is no not more than 6 months, this is the acute infection. If it is both positive and more than 6 months and statement of chronic liver disease, then you label as a chronic hepatitis. If the hepatitis C virus antibody is there, no PCR is negative, so this shows the resolution of the hepatitis C virus. And if it is only hepatitis C virus RNA by the PCR is positive, it shows early acute hepatitis C infection, chronic hepatitis C virus infection in immunosuppressive stage. So there is a antiviral drugs in hepatitis C, combined peg interferon and ribavirin. So 45 to 62% sustained viral response is there, better response in genotype 2, 3, low pretreated viral load, younger age, absence of cirrhosis. Now there is some other drugs, antiviral drugs are used. It's more commonly used in the adults, but in the pediatric now still trial is going on for the SOFAs. This is the new drugs for antiviral drugs. There's no vaccine. So there's no good news for the hepatitis C because there is no effective vaccine for hepatitis C. Now we have to discuss in detail for what is the chronic liver disease, well known CLD. So now we discuss chronic hepatitis. So there will be no chronic hepatitis for the hepatitis A in the B, hepatitis A in E. But yes, hepatitis B and C can go into the chronic hepatitis. So we discuss that what is the chronic liver disease, what is chronic liver disease is chronic hepatitis and liver cirrhosis. So combined with the chronic hepatitis with liver cirrhosis, the chronic liver disease. There will be multiple causes, common manifestation. The manifestation will be a single one, chronic liver disease. But there will be multiple causes. We have to go into detail that how we have to identify the causes for chronic liver disease. So what is the chronic hepatitis more than 6 months, and what is the liver cirrhosis? A consequences of chronic liver disease characterized by replacement of liver tissue by fibrosis and regenerative nodules, leads to the irreversible loss of liver function and its complication. It can be micronodular and macronodular cirrhosis. So what is the etiology in pediatric for the chronic liver disease? Can be metabolic causes. I'd say that's a single manifestation, presentation, but multiple causes. It can be alpha-1 deficiency, cystic fibrosis, fructosemia, glycosemia, Gaucher disease, glycogen storage disease, type 3, type 4. And if it is due to infectious, we discussed already viral hepatitis, cytomegalovirus, chronic hepatitis B, and D. Regarding hepatitis D, virus is defective for replication, so needed superinfection or co-infection by the hepatitis B for the hepatitis D. It's diagnosed by hepatitis IgM antibody, and the treatment is only you have to treat for hepatitis B. Hepatitis D treatment will be here. So if you want prevention for hepatitis D you have to need for vaccination for the hepatitis B. Regarding infected disease by chronic hepatitis C, herpes simplex, rubella, semicolonitis can lead to the chronic hepatitis, chronic liver disease. Inflammatory disease like autoimmune chronic active hepatitis, primary sclerosing cholangitis can lead to the chronic liver disease. There is some congenital malformations or some syndromes which can present from early age for the, like they will be present with the itching, cholestasis, deep jaundice, bleeding. First 2 to 3 months of the life, the most common cause of this is the bleed atresia. And other are atriohepatic dysplasia, Algeri syndrome, intrahepatic biliary hyperplasia, oligocysis, congenital hepatic fibrosis, intrahepatic cystic biliary diabetes like Caroli disease. Some vascular lesions can lead to the some blood pressure in the hepatic veins like Budd-Chiari syndrome, hepatic vein thrombosis, congestive cardiac failure, congestive pericarditis, veno-occlusive liver disease, veno-caval wave can lead to the chronic liver disease. Toxicity like sometimes mushrooms, organic solids, and psychoactive drugs like INHE, rifampicin, and valproic acid can lead to the chronic liver. It is untreated and diagnosed. Idiopathic, sometimes cerebral hepatorenal syndrome, Zellweger syndrome, familial intrahepatic cholestasis, thyroid disease, and neonatal hepatitis, and giant hepatitis. Particular presentation of chronic liver disease, the patient can be failure to thrive, anorexia, nausea, vomiting, prolonged or recurrent jaundice, pruritus, pain in abdomen, colicky, abdominal distension. Features of portal hypertension will be here in history, erythemesis, melena, epistaxis, fever. Sometime it will be not common presentation. Decompensated liver, there will be fever there. Other points in history like fever, prodromal symptom, nausea, vomiting, jaundice, young individual if they have like Wilson disease, extrapyramidal symptoms will be here, neuropsychiatric manifestation, anemia, and Wilson disease, bleeding, colicky, abdominal pain, jaundice, fever, gallstones, drug history, sometimes stomach poisoning. Sinus symptoms are cholestic disease will be here, fatigue, malaise, anorexia, biliary colic, jaundice, pruritus, abdominal pain, pancreatitis, and stool color. Like in the biliary atresia, we are keen to interest for what is the stool color. If it is clay color, gray color, normal, it is yellow color. If it is clay color, mitti ki tarah color of the stool is clear, then you say that this is the obstructive jaundice can be due to the biliary atresia. Then some physical findings you can found in the chronic liver disease like cold growth, malnutrition, fever, muscle wasting, skin, jaundice, flashing, pallor, palm erythema will be there, spider nevi, digital clubbing, abdominal examination of coronal disease, abdomen will be distended, umbilicus will be everted, caput medusae, ascites, pleural shift dullness will be positive, large tendon liver, shrunken liver, large spleen, and rectal varices on abdominal examination here. CNS examination, hysteresis, positive basis reflex, prolonged phase of D reflex, mental status, if there is a encephalopathy is there, then the lateral sensorial will be there. Then you have to go investigations, fully standard investigation, the liver biopsy will tell you that there is a cirrhosis or not cirrhosis. Then LFT, you have to LFT, bilirubin will be raised, SCBT will be raised, alkaline phosphatase, gamma GT, increased bilirubin, low albumin, increased globulin, PTF, INR will increase, thrombocytopenia, there is hypersplenism, low sodium. Ultrasound will show that shrunken liver, cirrhotic liver, portal vein pressure will be increased. Endoscopy, finally, if you want to look for the varices or if there is a bleeding, then diagnosis by the endoscopy. There is another investigation for hepatitis B virus. You go for the hepatitis antigen, E antigen antibody, hepatitis B virus and hepatitis B virus DNA. For hepatitis C, you go for hepatitis C virus antibody and hepatitis C virus RNA by the PCRs. For serology urine for CMV antigen, for Epstein-Barr virus, because PBV serology, heterophil antibody for the Epstein-Barr virus, bacterial cholangitis is good for the blood and liver tissue culture. For the autoimmune chronic hepatitis, we think for you go for ESR will be raised, ANA, antinuclear antibody, anti-synopus antibody, antimicrobial antibody, and liver kidney macrosome antibody will be positive in if it is within for the autoimmune chronic active hepatitis. Then, if you suspect for alpha-1 deficient, then serum alpha-1 antitrypsin level and TI type. Glycostorage disease is the most common cause. Type 3 and type 4 can lead to chronic liver disease. Lactic acid level, fasting blood sugar, will be low uric acid, liver and muscle tissue enzymes, and finally biopsy. Liver biopsy can diagnose for by the glycostorage. Lactosemia, yes, urinary non-glucose, UV6 will be positive, red blood cell, galactose phosphatase, blood transfer level will be increased. Tyrosinemia, level in urine, organic acid, or hematochromatosis, gene, one of the cause of thalassemia can lead to chronic liver disease. Iron will be increased, ferritin level will be increased, and you go for serum iron and TIBC in ferritin level. If the cause is for cystic fibro, then sweet pruritus genotype delta 508, you can go for toxic injection for the stomiphen, paracetamol, and for the Wilson disease. Wilson disease is the most common cause for the chronic liver, not most common, but can be cause for the Wilson disease. The patient come with the, there's a different presentation for Wilson disease. It can involve the eye, can lead to chronic liver disease, can be hemolytic anemia, and can involve the CNS. So you have to look for by serum copper level, serum plasmin, 24 urinary collection for copper, and slit investigation for the calf ring and liver biopsy. But routinely we're not going for the because need dry liver for the measurement for serum copper, for liver copper. This chart for which seems to be busy. If it is less than 6 months, you go for this investigation. With more than 6 months already, we have discussed that how you have to go for investigation for the cause. Finally, if no cause found, then yes, the liver biopsy can diagnose, confirm the diagnosis for CLD and can help for the etiology. Then there is a complication of chronic liver disease like ascites with the presentation and complication of chronic liver disease. Sometimes patient can develop spontaneous erythropoietitis, parietal bleeding, patient become bleeder like metastasis, hepatic encephalopathy is also a complication for the chronic liver disease, hepatorenal syndrome, hepatocellular carcinoma. So these are like on patient examination, you see like there will be sinus symptoms for the portal hypertension like ascites and capillary vagus will be there. On endoscopy, they look like varices, esophageal varices by the upper GI endoscopy will be look like this. Rectal varices by lower the GI by the colonoscopy, rectal varices, hemorrhoids will be here. And then finally, if there is a massive splenomegaly, hypersplenism there and thrombocytopenia. So these are signs of the portal hypertension. So what will be the management for the chronic liver disease, CLD? Aim is to retard the progression and reduce the complications. So we have, because already there will be chronic liver disease and you have to see the underlying causes there. If it is still treatable cause or not treatable cause. And you have to vaccine for hepatitis A and B. If it is not hepatitis B, then you have to hepatitis A and B. If hepatitis B is there, then you have to vaccine for hepatitis A. and treat if there is a underlying cause is found and treatable. If the patient have ascites, you have to look for salt and fluid restriction. Diuretics, you have to advise splenectone plus minus glucosamine. Sometimes if there is some massive ascites is there. Large volume paracentesis is big, this disturbing. Huge ascites is there. With the massive or refractory ascites not response to the splenectone, then you have to go for the remove that fluid removed by the replacement of the albumin. To avoid, if you do not use the albumin, then the patient can develop symptoms. Sometimes tips transfuse the intrahepatic corticosteroid, but now it's not routinely used. If the patient responds bacterial, there will be abdominal pain, fever, and worsening of ascites and encephalopathy will be there. Treatment by diagnosis, paracentesis, take the ascitic tape, and you go for the DR in culture. There will be polymorphic neutrophil more than 250 microliter, and culture will be positive there. Then drug choice, vaccines, ceftriaxone, ciprofloxacin can be used. If there is a varicose bleeding, yes, it is varicose dilating submucous veins in esophagus or stomach. Cause is the portal hypertension, 80% of GI bleed, and probably liver disease. Sometimes patient will be late or sometimes early presentations. There will be no patient came first for the hematogenesis and go for the no past history and only spleen is palpable, no ascites. You go for the endoscopy, it is diagnosed with a portal hypertension, then go back for the liver enzymes will be raised or diagnosis will be established by school because BRC. Vice versa can be there. Risk factors for bleed like size of the varices, severity of liver disease, and well marking. So endoscopy findings can be there. So diagnosis varices is by the upper GI endoscopy. So it will look like this will be varices when go for the endoscopy, and this is the signs of the portal hypertension. So management of varices acute, and we have to prevent the rebleed. Acute is resuscitation if the massive bleeding, patient is short, you have to resuscitate by the boluses, normal saline, hemocell, or if it is blood, replacement of the blood, and if it is very sick, CPR can be needed. Then you can use FFP, platelets, vitamin K, telrepressine, octreotide can be used. Lactulose if there is a constipation is there. Upper GI endoscopy, so diagnostic and therapeutic also. So you have to look for the varices, and then you have to want to stop the bleeding by bending or sclerotherapy, sometimes balloon tamponade, and then yes, like the tips or surgery. Prevent the rebleeding by band ligation. You have to over repeated sessions. You can use non-selective beta blockers like propranolol, nadolol. Tips for recurrent bleeding, surgery, portal system shunt, and finally, if you want liver transplantation. Hepatic encephalopathy already we discussed. There's the 4 stages: stage 1, 2, 3, 4, and 3 and 4 is irreversible. Only treatment is the liver transplantation. So we can feel and drowsiness, tuber coma can be in hepatic encephalopathy from liver disease. Pneumonia identified. Precipitant factor like GI bleeding, constipation, closis, hypokalemia, sedatives, paracentesis. Tips is also if the procedure, the procedure is done for, it can lead to the encephalopathy. So there will be signs of CLD with steresis and ultrasensorium encephalopathy. Management of hepatic encephalopathy, correct underlying precipitant factor, if there is electrolyte imbalance, hypoglycemia, if there is constipation, is there, if there is infection, we have to treat. Avoid sedative drugs which can lead to the hepatic encephalopathy. Restrict dietary protein intake, and you can use prophylactic lactulose, keep the 2 to 3 uses per day. Oral antibiotic like metronidazole, amphetamine, lumicin can be used for the patient of the hepatic encephalopathy. Hepatorenal syndrome occur in patients with advanced CLD and ascites. marked by renal impairment, the absence of any renal metabolic disease or shock, oliguria, hyponatremia, low urinary sodium can by raised creatinine, and sometimes albumin fusion with the vasoconstrictors, liver transcription is choice for the hepatorenal syndrome. Peripheral carcinoma, very rarely you see in the pediatrics, most common in the adults, because it takes years, 15 to 20 years to develop the peripheral carcinoma. But if they have chronic liver disease, we have to follow. Associated with the cirrhosis, 80% suspected if worsening of CLD, large liver, hemorrhagic ascites, or if there is a weight loss is there. Diagnosis by CT, MRI with the contrast, and with the respiratory endoscopic liver, alpha-fetoprotein with base, liver biopsy confirmatory. Treatment, early resection, advanced liver transplant is a local plate treatment. Screening that we have to follow for the chronic hepatitis or chronic liver disease. If there is a cirrhosis, the patient not develop, or if it develop, early diagnosis is screening. Every 6 months for ultrasound and alpha-fetoprotein level for every 6 months to diagnose hepatitis C by screening. Liver transplantation is the treatment for the industrial liver disease, but in Pakistan it is outcome is not good one. But now yes, hope is there. There's some centers which where liver transplant is available now. Reports are coming that there is a pediatric liver transplantation going on. There are some issues for liver transplantation like donor, cost, technical expertise, graft versus whole disease, and recurrence of the disease or chronic liver disease. Thank you. Yeah.
Question answer.
See, anybody have any question regarding chronic hepatitis B, C, chronic liver disease? कोई सवाल, कोई जवाब, कुछ समझ में आया?
नो सर,
सर क्या सवाल नहीं है? कोई कुछ समझ में नहीं आया?
सवाल नहीं है,
सवाल नहीं है, मैं समझ में सारा आ गया. वेरी गुड. Anybody else? Anybody want to question? No question? Anybody? Someone have a raised hand in between. Okay, thank you, Hafiz.